I cordially invite our keynote speaker to open the conference today. Dr. Senjuti Saha. She is a scientist at the Child Health Research Foundation in Bangladesh. She will be speaking about her work and lessons learned from COVID-19 in low and middle income countries. Welcome, Dr. Senjuti Saha. Over to you.
Thank you. Thank you so much, Aditi, for that introduction. And I am so pleased, so excited to be here. Thanks to MSF for this platform to speak to you and share some of what we have learned during this pandemic. So let me clarify my positionality here. I am a scientist based in Bangladesh, and I work in global health. I'm almost a mid-career scientist. And oftentimes, because I work in global health, I find myself in meetings with a lot of global collaborators, in small rooms with meetings, oftentimes dominated by white males. And as I work in global health, I often feel that there is this sense that people like us, countries like us, need saviors from the global north to come help take us out of different problems. And that is really reflected in the way a lot of the global health projects are designed, where oftentimes samples are shipped from the global south to the global north, data are shared, and when published, often they are under their ownership. However, when the COVID-19 pandemic started, things changed because everyone around the world became busy with their own epidemics. They became busy with their own patients, with their own samples. Samples were no longer required to be shipped because countries had their own samples. And suddenly, countries like ours, for example, Bangladesh, were left in a vacuum where we were on our own. We had to figure out ourselves how we will deal with this pandemic. And really, I want to share with you some stories, a story that I have been able to be part of. And what I have learned is how resilient we are in South Asia, how intelligent we are, and I think most importantly, how quickly we can adapt. And I want to leave you with some questions about what are we going to do with these lessons? Let's all start thinking now. So I hope you can all see my screen. This over here is my title slide, and these three amazingly brilliant Bangladeshi women have been the leads of our COVID-19 diagnostic lab in Bangladesh that I'll talk a little bit about. So I worked at a not-for-profit NGO in Bangladesh called the Child Health Research Foundation. And in this NGO, really, we try to understand what are the causes of diseases. We've been working in Bangladesh for several decades now. And what we do is basically try to understand what causes disease. So we work from a microbiological perspective. We conduct fever explorations. We try to understand what causes outbreaks. When there are outbreaks, we try to track the outbreaks. For example, we are doing that for SARS-CoV-2 now. We've done that. We do that for dengue and chikungunya. I mainly focus on meningitis, try to understand what causes meningitis, what are the next vaccines, for example, that should be introduced, and use all of that data to translate into policies. And we work with policymakers to bring about changes in the country. So we have multiple projects usually running at our foundation, but suddenly everything stopped when the COVID-19 pandemic hit. On March 8th, the first 3 cases of COVID-19 was detected in Bangladesh. I remember that day so well because it's the International Women's Day, and we were all celebrating, and our day ended with the first 3 cases, news of the first 3 cases. On the 24th of March, when the first 3 cases were detected, there were only 1 lab working to test possible COVID-19 samples. On the 24th of March, because of our history of working with several pathogens, the government of Bangladesh asked us if we could become a part of the diagnostic labs in the country and could become an extension of the government. So the next 5 days, we worked day and night to build a COVID-19 lab, doing refresher trainings on virus detection, figuring out ensuring we have enough PPEs, buying and setting up biosafety cabinets, building special rooms, etc. And by the 29th of March, we were ready. We were ready, set, go. We said, okay, we can now deal with hundreds of samples per day. But we were ready as a lab. However, it turns out Bangladesh wasn't really ready. We were ready to handle hundreds of samples per day, but there were only 10, 20 samples trickling into the lab. And then that made us question why. What was the problem? What were the barriers in receiving these samples? And it turns out there were three main barriers. Number one, there was this overall confusion on privacy. We were just learning about COVID-19. There was a lot of stigma against people who tested positive, and also people did not know where to go to give the sample. So what we did is we immediately, all of those people who have been working on other projects immediately, together we set up public phone lines. We started sharing that phone number so people could call us, we could answer their questions. But even after that, we realized that the places that were collecting the samples did not have the training of collecting samples. They did not know how to, even after collection, how to transport the samples, how to use the PPEs. So we started building all these training programs online, on-site, off-site, however possible. And once people were trained, we realized there was a third problem, is they didn't have the equipment or the resources to collect the samples properly. Sometimes we would get glass test tubes with samples with cotton at the end of a coconut tree stick. So then we came up with this kit that we started distributing to all the collection facilities where, we gave them instructions, we gave them all the things that are required to collect the samples. And within days, very, very quickly, within days, from 10 samples per day, we quickly went up to hundreds of samples per day, so many that we were having a hard time keeping up. In order to troubleshoot, we made this real-time tracker or dashboard so that, anybody sitting anywhere could track all the number of samples coming in and the epidemiology of the patients who were giving us the samples. This is what we were doing by the day. By the night, we realized that vaccines were already being designed. There were several groups around the world designing vaccines, and soon they would be in clinical trial, which meant sequencing the virus was extremely important. So we worked in the lab, in the testing lab by the day, and by the night, we were figuring out how to sequence the samples. We contacted all our friends, we started getting all the reagents ready, started reading as much as we could. And by 11th May 2020, we became the first lab in Bangladesh to sequence SARS-CoV-2. But that was only one sequence, right? Our first was only one sequence, and that wouldn't really tell us much about what's happening in the entire country. Sequencing has to be done systematically. What followed after we announced the first sequence from Bangladesh is phenomenal. Within 1 week, another lab joined us and started sequencing. Soon, there were over 15 labs who shared protocols amongst them, started talking amongst them, started, digging out machines, reagents, equipment that have been sitting in boxes or bubble wraps, and joined this effort of sequencing, such that, Bangladesh started being discussed in different forums about how well the country is doing in the sequencing front. To date, we are tracking all the viruses. We're constantly updating our policymakers on the variants that are circulating. So really, it's been a phenomenal experience, and shows the strength and adaptability of countries like ours, of South Asia. In 18 months, really, we went from 1 PCR lab in the country to 180 PCR labs. And there are almost actually 800 labs doing different kind of testing for SARS-CoV-2. We started with one, and it's only been 18 months. From one sequencing lab, Bangladesh didn't do a lot of sequencing before this, right? We couldn't even think we would be doing RNA sequencing in the country. From one lab, there are actually about 21 labs now in the country sequencing. But why does it matter? What does it really mean, right? COVID is here today. We don't know. I mean, no matter what, we will fight COVID. We will fight COVID. This pandemic will be over. So what's going to happen to all of this capacity that we have built ourselves? What's next? Just like SARS-CoV-2, tracking every other pathogen is equally important. SARS-CoV-2 has received a lot of global attention because it's a disease that affects all, but understanding or testing for pathogens, tracking the pathogens is extremely important for all viruses, all bacteria that affect us, whether it's MDR-TB or dengue or chikungunya. And my question really constantly to myself, my organization, my country, to entire South Asia is, can we use this momentum? Can we use this energy that we're seeing within the scientists of our countries to develop such platforms, to take this interest to other pathogens? I'm going to end with this slide. And over here, what I'm showing you is this phylogenetic tree that I've already kind of touched upon before, where every dot is a genome. And really globally, more than 2.6 million SARS-CoV-2 viruses have been sequenced because it has global attention. This is global. In Bangladesh, we have sequenced more than 2,000. Unbelievable. SARS-CoV-2 is a new virus, right? COVID-19 is a new disease. And already we are seeing so many sequences. Let's compare this to dengue. Look at how sad the dengue global phylogenetic tree looks. Only a few samples have been sequenced from the entire world over the past few decades. Only 5 or 6 dengue virus has been sequenced from Bangladesh, and only 2 have actually been sequenced within Bangladesh. My question to myself and everyone is, how do we take this capacity that we have built for SARS-CoV-2 for other pathogens, for tracking other pathogens that affects us? There is no really global attention towards dengue, towards MDR-TB, towards chikungunya. How do we now change the maps of these pathogens? Because unless we can do that, we will never be able to close that 1090 gap. What is the 1090 gap? When we look at where most of the children in this world die, we see really deaths are concentrated in the global south. So every dot, every maroon dot here represents deaths of 10,000 children. Now let's look at where all the technologies exist. There is really very little overlap. This is the 1090 gap, where 10% of the resources exist where 90% of the children die, or 90% of the children die where only 10% of the resources exist. We have to close this gap, and it is our responsibility. And I'm really hoping that COVID-19 actually somehow given us this chance to realize our resilience, our adaptability to bring about changes to close this gap. With that, I'm going to end by saying everyone should receive the benefits of science, and everyone should have the ability to practice science across the world. Thank you.
Thank you so much, Dr. Senjuti. It's indeed important to learn lessons from different countries to make healthcare accessible for everyone.